Thanks, everyone. I know I'm the only one standing between you guys and break, so you'll be happy to know that I only have 150 slides. So, anyways, I'd also like to say thanks to all you guys for coming here. We're big believers in the team approach to our care of our patients, and I can't count the number of times it was a nurse or a tech in a room that kind of contributed to the case and provided a good outcome, and it's all based on this type of learning. So. We're going to move from veins of the leg to arteries of the arm, and I'm going to talk about radial intervention. Here's a brief outline here. Going through the historical perspective, this was first done in the 1940s, originally with large catheters, which precluded use of the radial routinely. In 1989, Dr. Campa pioneered radial angiograms, and the first PCI was 25 years ago with Dr. Kemeny. The rationale is obviously we use a lot of blood thinners. Bleeding remains an important problem. And when people do bleed, as we'll see, there's not good outcomes, and transradial interventions reduces bleeding. Of course, patients prefer this. I can ambulate immediately and often leave the hospital faster and save money. Looking at the NCDR data, this is large data collection from America, and by presentation you can see that the more acute your presentation, the more likely you are to bleed. Within each pie chart there you can see there's access site bleeding is still very relevant. That's the blue portions, so it's a big problem. A meta-analysis of bleeding in acute coronary syndromes demonstrated that if you do bleed, you're 7 times more likely to die if you have a PCI, an ACS, and have a bleeding event. Now, there's different types of bleeding events, as we mentioned. Non-access site bleeding. Access site bleeding is definitely very bad, but non-access site bleeding, rather, is still important. So if you do bleed, this is more pooled data. This just shows, again, other outcomes. MI and stroke are also significantly increased. So there's a lot of debate in transradial and transfemoralists, but one thing that can't be debated is that if you go transradial, you do have a reduction in bleeding and vascular complications. It's a large meta-analysis that showed a 73% reduction by a transradial approach relative to transfemoral. So looking more into the prospective data, which is what we like to use when we kind of make treatment changes, a lot changed with the Radial trial, which was the first large randomized trial in ACS patients of femoral versus radial. It was ACS and STEMI patients, 7,000 individuals enrolled, and they were randomized to access site. Now, the primary outcome, which was ischemic outcomes as well as bleeding, was not different between the two. So technically a negative trial, but it showed feasibility of doing these sicker patients via the wrist. Importantly, as expected, significant reductions in bleeding and vascular site complications. Another important finding from this study was in the subgroup analysis. Now, this wasn't pre-specified, but when they looked at the STEMI group in the Radial trial, they noticed a significant reduction in the primary endpoint, specifically in death. So there was a 2% absolute risk reduction in death in patients who got their procedures transradially. But of course, this was hypothesis generated. It wasn't the design of the trial. So that hypothesis generation led to prospective trials in STEMI patients. This is one of those trials, 700 patients in Prague, the STEMI Radial trial. They looked at just the bleeding outcome as a primary outcome, which was, again, significantly reduced in the radial patients. When they looked at their MACE ischemic outcomes, they were numerically lower in the radial group, but not statistically significantly so, but a little bit smaller numbers. When the bleeding and ischemic outcomes were combined in the NACE, again, as you can expect, a significant reduction in bleeding. Another trial similarly done, this is in Italy, 1,000 patients, experienced centers, very, very sick patients. They included shock patients, were randomized to femoral or radial procedure for their STMI treatment, primary PCI. You can see significant reduction in bleeding and the net clinical outcomes, which were their primary outcomes, but MACE also was reduced. When they looked at the components of the MACE, they saw that it was driven actually by the most important of that ones of those the component, cardiac death. This is a 4% risk reduction, which was hard for people to believe, but again, they did include sicker patients. As far as the bleeding in that trial, it was clear that all the reduction was in access site bleeding, so the patient groups were otherwise equal in terms of their non-access site bleeding risk. This led to what really was kind of the trial that put everything over the hump, I would say, the Matrix trial. 8,000 patients, very contemporary treatments, transradial versus transfemoral. It was a very complex randomization. They looked at heparin and bival as well, but looking at the access portion of this, again, looking at MACE and NACE outcomes at 30 days, the MACE outcome was reduced in the transradial group. It wasn't statistically significant. They set an even more stringent requirement of 0.025. When they added the bleeding to create the NACE outcome, it was a highly significant reduction, again, about 2% reduction in outcomes with radial procedures. Concurrent with this publication, an updated meta-analysis of all randomized trials of transradial versus transfemoral was published, and they showed that the pooled data showed, was pretty undeniable, a 28% reduction in death with a transradial procedure compared to transfemoral, with no increase in the stroke as people had feared. It's interesting to know that this benefit was largely seen in the centers that were high volume centers or experienced centers. And high volume centers were those that did radial procedures 80% or more of the time. The medium and low volume centers were equal, but that just speaks to the fact that we should all be striving for this. This is true of the Radial trial as well, that the high volume centers derived the benefit. So some more outcome data and some other endpoints. Acute kidney injury, this was a pre-specified endpoint trial, and also the Matrix group that showed that kidney injury was reduced 15% in the radial group versus 17%, defined as a rise of 0.5 or 25% of the starting creatinine. Importantly, that the benefit was largely seen in the sicker patients, those with lower GFRs to start, older patients, those in shock, and those that had a higher Miron score. So this is all great data, but let's put it in perspective. I'm not sure how many in the room remember the era of TPA versus streptokinase, but this was a huge step forward for us using TPA versus streptokinase in STEMI with a 1% absolute risk reduction. This is a pivotal NEJM study. We obviously moved to primary PCI when available, which demonstrated a 1% to 2% risk reduction relative to lytics. Subsequently learned that doing this quickly saved lives, so door to balloon times in the 60 to 90 minute range provided an equal benefit. And that's the level of benefit that we're talking about with transradial intervention. So very similar to these other paradigm shifting type treatments. So really, really important stuff in my opinion. So how is that translated into the guidelines? Let's look at the US guidelines, which are a little bit dated here. This is the 2011 ACCH guidelines for PCI, and it gives a 2A recommendation, which is generally recommended with a level of evidence of A, which is strong level of evidence. When we look at the American guidelines for STEMI, it's not formally recommended, but there is some text phrase of to be considered when feasible in experienced centers, which is a pretty soft statement. The 2014 American guidelines for acute coronary syndrome, so this is non-ST elevation MIs, it's not mentioned at all. So it's pretty hard to reconcile the data and these guidelines. When we look at our friends across the pond, the ESC guidelines in 2015 upgraded their recommendations in ACS to class 1 level of evidence A, which is the strongest possible recommendation. This is true, and these slides aren't in here, for 2017 update they had for STEMI treatment. So what is our actual utilization of radial intervention? And maybe I can get a show of hands here of those that have work in predominantly radial labs. Maybe if you could just raise your hands. So there's a big light in my face, but it looks like maybe 20%. Which you'll see kind of is about where we're at. This is, again, NCDR data from 2013, 3 million patients in America that are all reported here, as you guys all know. This is in 2012. The rate was 16%. I put this slide in here to show that certain groups were underrepresented. Women those older than 75 and patients with STEMI, and those that were not getting procedures in the Northeast were even less likely to get a radial procedure. Again, a little bit dated. This just shows in that study that the procedural success was equal. It's just that the rates of use were less. This was updated in 2016, and that showed that our rate was up to 25%, so 1 in 4 patients. And this is just regular, stable patients, stable and acute coronary patients, not just STEMI patients. So for those of you that work in the VA, you're aware of the CART system. This is a pooled analysis of VA patients getting PCI. In 2009, it was 5%. In 2015, it was up to 32%, so somewhere in the 20 to 30% range. Unfortunately, despite these low numbers, it turns out that those who are most likely to benefit from a radial procedure, those are least likely to get it, and that's demonstrated here. There are 3 groups here with predicted risk of bleeding with a femoral procedure. So those with the highest predicted risk of bleeding with a femoral procedure also had the highest use of a femoral procedure. So this is actually, we tend to use a radial procedure in those who are least likely to benefit from it, which is a risk treatment paradox. What about for STEMI? This is data from the United States, about 25%. So if you can imagine with these absolute risk reductions in mortality, if we extended this to numbers like in Europe, we could save quite a few more lives. This is a STEMI trial from Sweden, the Validate Sweetheart study. I wasn't looking at transradial versus transfemoral, but I included it just to demonstrate that in this trial of 6,000 patients with MI, 90% of them were treated transradially. So a lot of yield that's being left on the table there. So what about patient selection? And in our lab, this is very important. Our techs and nurses really contribute, and they know this data, and they speak to it and try to get us to convert cases that are scheduled as transfemoral cases. We know that transradial procedures fail more often in older patients, those with bypass and those who are extremely short, but there are ways to get around this. Here's a specific kind of graphic representation of that. Those less than 5'5" tend to have a higher rate of failure because of a shorter aortic root. This is another trial that created a score assigning points for female gender, bypass surgery, and CABG. The more of those points you had, the more likely you were to have a transradial failure. But again, this is all in the context of experience, and the Europeans published a kind of an algorithm to incorporate radial PCI, and I think it's very reasonable, starting with easier patients and escalating to the sicker ones. What about complications? This is an important part, a limiting step. Radial artery occlusion is the big one. It's generally asymptomatic. It's related to sheath size. The larger the sheath, so we're using smaller devices. Many of you are familiar with the slender sheath, which basically has the same internal lumen, but a thinner wall, so the outer lumen is smaller. It's allowed us to reduce radial artery occlusion. We've learned that full anticoagulation is appropriate in all patients. Different heparin doses from none, intermediate to full reduced the radial artery occlusion rates. We know that Coumadin is not sufficient, so those on Coumadin still require full anticoagulation. And most importantly, patent hemostasis. So what that means is, maintaining hemostasis without occluding the artery. There's a trial that looked at this pneumatic TR band closure device at an equal pressure to the map compared to double the pressure of the map. And the patients that had occlusive pressure on their site after the sheath was removed had a higher risk of occlusion. How do we practically test it? Something called the reverse Barbeau. So with the device in place, we'll compress the ulnar artery, and if the radial is still patent, we'll maintain a pulse ox tracing, and that's what you want to see. This is a randomized trial that showed in short and long term still reduction in artery occlusion with patent hemostasis. It's kind of taken us to the next level, and some experienced centers published this study called the PROPHET trial, which looked at ulnar compression. So this was purposely occluding the ulnar artery upon removal of the radial sheath to improve flow down the vessel that we had cannulated. And they showed by doing so, you could reduce the risks of radial artery occlusion even further at 30 days, 3% in the standard patent hemostasis group to less than 1% in the ulnar compression group. What about spasm? I think many people in the room here are probably aware of this phenomenon. It's preventable. Sedated patients picking the right tools and giving anti-spasm medications. It's more common in young women who aren't sedated well with multiple access attempts. This is a graphic angio representation. You can see the spasm before and after the treatment with verapamil. This is an ultrasound showing the amount of caliber change the radial artery is capable of. When spasm gets critically bad, and in almost 15 years I've never seen this, you can obviously sedate the patient aggressively or do general anesthesia or regional block to remove the catheter. Prevention is best here, having patients, sedation, very, very important. Perforation, this is a real risk. It's not frequent. A lot of small muscular branches of the radial artery, so these are different than a transfemoral procedure. Again, rare, more common in older folks and those with hypertension, more brittle vessels. This is an angiogram recently. You can see a fellow was a little aggressive with a wire and caused a perforation. The important thing to know is even when someone has a perforation, it's generally very easily managed. We pass a catheter across, we did the whole intervention, and the simple presence of the catheter there causes internal tamponade, and these often resolve on their own. It is important to kind of monitor the hematoma. There's different grades, and if the hematoma does reach to the elbow, we definitely have a heightened awareness for a compartment syndrome, which is catastrophic and just requires post-procedural monitoring and potentially evaluation. So what about the patient's experience? This is a service industry that we're in. Essentially, quality of life measures, all different metrics of quality of life are improved with transradial procedures. I think those of you that work in the lab probably know this or see patients that specifically request radial procedures. This is data from the Radial trial. Those 7,000 patients randomized were asked if they had to have another procedure, would they like it by the way that they were randomized to. And in the radial group, 90% said yes, and the femoral group, only 50%. And of course, 50% didn't have complications, but half of those patients had a bad experience, such that they would not want it the same route. What about the operator experience? I'll kind of rip through these a little bit faster, so I'm running low on time here. This just shows that the level of experience, really at about 50 cases, it starts to level off in terms of fluoroscopy time use. This shows that radiation decreases with higher volume, and the differences become less statistically significant. This was looked at in that same matrix trial, which generated a lot of sub-studies. Again, there was higher radiation, so it is an important concern in the transradial group for the operator at different points on the operator's body, thorax, wrist, and eye. A meta-analysis did look at this over time of all the studies that looked at radiation, and it is important to notice that back in 25 years ago, there was about a 2-minute increase in fluoro time between transradial and transfemoral, and that gap is narrowing. And it's largely, this just shows that right radial artery does have a higher fluoro exposure as well for the operator and staff, although it is more comfortable than a left radial. This gap is narrowing because our practices are getting better, and this is a publication from Best Practices publication that shows that we don't need to fluoro all of the wire passages. We can save things on fluoroscopy instead of cine. But the bottom line is low radiation operators, and again, you might know this in your lab, low radiation femoral operators are low radiation radial operators. It's people that do things correctly with the pedal and the shields. So lastly, from the hospital perspective, how does this measure up? Well, length of stay is significantly reduced with transradial versus transfemoral to 0.4 days, which is basically like half a day, which is hugely relevant to the bottom line. You can see in all patients, there's about an $830 per patient savings with the transradial versus transfemoral, with the highest risk saving $1,500, and that's on extra time, labor costs, room costs, and extra testing. There's a big meta-analysis in England that was recently published, which looked at 300,000 patients, similar findings. Busy slide here, but 200 pounds saved due to length of stay of the total of $250. So in conclusion, transradial does make sense. Well, it's good for the patient, it's good for the staff, and it's good for the hospital. So hopefully you guys can all increase that or help increase it at your local institutions. Thanks a lot for your time.